Good evening and welcome to everyone to our Men and Breast Cancer Forum this evening. Tonight's forum, we're talking about treatment, managing side effects and finding support. Firstly, I'd just like to, Breast Cancer Network Australia respectfully acknowledges the traditional custodians of the land in which we're meeting in the digital space tonight, the Wurundjeri people of the Kulin Nation, their spirits, ancestors, elders and community members past and present. A big welcome to everyone and thank you for joining us in the evening tonight. In 2022, it's predicted that 212 men will be diagnosed with breast cancer in Australia, and for men, the diagnosis can be particularly confronting, and it may bring many different challenges. It's really important to know for everyone on the call to know that there's a range of support available to you and to your families. Treatment for breast cancer may include surgery, chemotherapy, radiotherapy, hormone blocking therapy, and targeted therapy. We'll hear about some of them tonight from our guest speakers. And some of the most common side effects that provide a challenge for men living with and beyond breast cancer might include pain, lymphedema. We'll hear a bit about that tonight. Bone health issues, sleep problems, fatigue, cancer-related cognitive impairment, changes in sexual health and wellbeing, weight gain, anxiety, and other issues. This event, we really want to aim to provide an opportunity for you all to connect with other men affected by breast cancer. We'll also provide information about hormone blocking treatments for breast cancer, management of their side effects. We'll hear a lot about, John's going to talk a lot about lymphoedema, and then we'll end with some support and resources that are available to you. All right, there we go. My name is Andrew Smith. I'm the Manager of Information and Support here at BCNA. I have a clinical background as a cancer occupational therapist, and I've worked in the cancer sector in both clinical and the not-for-profit space for the last 18 years. It's a real pleasure to be with you all tonight and to be hosting the event tonight. A little bit of housekeeping. We've dedicated a fair bit of time for questions, and if people can jump into the chat to put their questions to our panelists, we will have some time a fair bit of time at the end of the presentations to go through as many questions as we need. If you wish to remain anonymous, please do not turn your camera on, and if you wish for your name not to be shown, please let us know in the chat now, and our brilliant support people will be able to update that for you. So without further ado, it's my pleasure to introduce our first presenter, Dr. Nick Zdenkowski, who is a medical oncologist, and I'll hand over to Nick to give an introduction of himself and kick off the proceedings for tonight.
Thanks very much, Andrew. So I will just share my screen, so bear with me for a moment. There we go. Okay. So I'm a medical oncologist. I'm based in Newcastle and in Maitland. So I consult up there. I have a focus on treating people with breast cancer, but I do some general oncology as well. So I do a part-time clinical role and have a strong interest in clinical trials at my Gateshead site. I also work for Breast Cancer Trials, which is the Australian and New Zealand Collaborative Breast Cancer Trials organisation. And through Breast Cancer Trials, I work as a medical advisor, and we run clinical trials around Australia, over 100 sites, over 800 members who all help with creating the evidence on which we base our clinical decision making. And we can certainly talk some more about that over the course of this evening. I'm a researcher, and so I'm very interested in the interaction with doctors and other health professionals and patients, and I take a real interest in communication strategies. In fact, my doctorate was in developing a decision support tool for patients with breast cancer considering chemotherapy prior to surgery. I acknowledge that we've got a fairly small group here, and so that means that I think we can have a good discussion. And so I'd like to address questions from the audience towards the end of this in our discussion. So I'll start by talking about the hormone blocking treatments and what the rationale is for using those treatments. It all comes down to subtype. And for men with breast cancer, the breast cancer subtypes are a little bit different to that seen in women. So we tend to see more of the hormone receptor positive breast cancers rather than the triple negatives and HER2 positives. So they're the way the cancer looks under the microscope. And if you've got estrogen receptor, that means that it's something that we can use a hormone blocker for. And that's what I'm going to focus on in tonight's presentation, is on the hormone blockers. And I'm not going to talk so much about chemotherapy. Now, decisions about chemotherapy for early stage breast cancer are very similar to that we make with women, depending on the stage, the grade, and the extent of the cancer, and decisions on a personal basis with the individual who's been diagnosed with the cancer. From a HER2 perspective, that's a lower rate than what we'd see in women, but still a reasonable number, and that involves HER2 blocking drugs such as trastuzumab or Herceptin, and chemotherapy alongside that, whereas for the triple negative breast cancers, it's chemotherapy is the mainstay of treatment. You can see in this little chart down on the left, there are the different subtypes, and there are a variety of factors there. You might hear of luminal type breast cancer, and luminal is just another way of splitting up the hormone receptor positive cancers. So the hormone receptors traditionally are estrogen and progesterone, and they are nuclear receptors on breast cancer cells, but they also exist on normal cells in both men and women. And this indicates a good prognosis cancer type stage for stage, but it also allows us to give blockers, so-called hormone blockers or endocrine therapy, that can then treat those cancers. The lower grade is the slower growing cancers, and they tend to respond better to the hormone blocking treatments, whereas the higher grade or faster growing hormone receptor positive cancers may be more responsive to chemotherapy, but still it's worthwhile to give hormone blocking treatment. So why am I going on about these hormones? Men have estrogen too, and the majority of that estrogen is produced by the testicles, by gonads, and it's then converted into estrogen in the peripheral cells, as well as there being a direct level of estrogen. And so that is relevant to male breast cancer. And hence the majority, 90% of male breast cancer is estrogen receptor positive. So there is the target. And on the other aspect of it is, of course, men have plenty of testosterone generally. That's also produced by the testes. And 97% of male breast cancer is androgen receptor positive. And androgen receptors are related to testosterone. The relevance of the androgen receptor is less clear at present than the estrogen receptor, and there is work looking at targeting the androgen receptor. Androgens are essentially testosterone and other male hormones. And this comes to our systemic therapy strategies for estrogen receptor positive breast cancer. So you can see in this panel on the right, what I was talking about before in terms of the estrogen receptor. In the middle of the cell, there's that nucleus, and there's estradiol, which is that estrogen hormone that can stimulate those cancer cells to grow. The estradiol gets inside the cell and then interacts with that estrogen receptor and tells that cell to make more and more copies of itself. And that's essentially what breast cancer and other cancers is uncontrolled cell growth. And there are a couple of ways that that estrogen can be developed through the testosterone being turned into estradiol via aromatase, and then that happens in predominantly fat cells, but also liver, muscle, and brain. The effect of the tamoxifen that you can see down that right-hand panel is that it technically is a selective estrogen receptor modulator, or a SERM. And that means that it has a partial blocking effect and a partial stimulating effect, but the end outcome is that it is a very good strategy to block the effect of estrogen and to help to control or eradicate breast cancer cells. And this is relevant after a diagnosis of early stage breast cancer, where a man might be given initially an operation and then chemotherapy if needed, and then after that a period of time on tamoxifen. And that might be 5 years, might be 10 years, depending on the stage of the cancer and decisions along the way about side effects and the risk-benefit analysis. So that's the mainstay of treatment. The other option is to stop the hormone production in itself. And that involves an injection initially with gazerolin, and we would typically add in an aromatase inhibitor like anastrozole, letrozole, or exemestane alongside the gazerolin injection to help maximize that estrogen and testosterone blockade. Another less palatable option, I must say, is surgical removal of the testes and then the addition of aromatase inhibitor. And that's not something that's done all that often. The gazerolin injection is reversible, but it does have to be given monthly in a breast cancer setting. So the benefits of hormone blockade versus the potential side effects. Now, there's a lot of knowledge that's extrapolated from studies of women, and unfortunately, with a rare condition, with, as Andrew said, 212 men anticipated to be diagnosed this year, we have less ability to do clinical trials looking directly at men. But there are more and more men going on to clinical trials with breast cancer, and we can discuss that a little bit later. We do have data to show that tamoxifen improves breast cancer survival, specifically in men. And it also reduces the risk of new primary breast cancers. So, for example, men with breast cancer are more likely to have a BRCA2 gene mutation that might have caused that. That being said, most men with breast cancer have a sporadic breast cancer, which is not caused by a gene that we know about. And so we do believe that tamoxifen reduces the risk of BRCA2 related breast cancers. It also reduces the risk of local recurrence, which is recurrence around the breast region, lymph nodes, and cancer coming back somewhere else in the body, and helps to control advanced or metastatic disease, which is when the breast cancer has gone to the bones, liver, or lungs. It's typically taken as a tablet a day for 5 or more years, and may be given with a monthly injection if it's a aromatase inhibitor. The benefits are greatest for those who are able to persist with a full prescribed course, and not everybody gets a side effect from tamoxifen. Some people tolerate it quite well. I did catch up with one of my male breast cancer patients today, and it's not everybody gets all of the side effects. Not everybody gets any side effects, but the main thing about the side effects, I think, is to say something and ask the question. So, is the menopause a thing? Well, this Time article that I'm showing on the right is not talking about breast cancer, it's talking about men in general. So that's just a small aside, and certainly we don't want men with breast cancer being administered supplementary testosterone. But it is a medically induced reduction in those sex hormone levels. And by sex, I mean gender-based hormone levels. And it does cause a range of side effects that can be quite troublesome, but they also can be manageable. So hot flushes, changes in mood, such as anxiety, depression, irritability. Irritability and anger can be a real issue in men who are taking tamoxifen, and it just seems to be just being a bit more snappy, a bit more grumpy, and if the people around don't realise that it's actually medication talking, then they might get a bit grumpy back, and can lead to some issues. Common to see fatigue or sleep disturbance, and they might be linked or they might be separate. So the sleep disturbance might be an issue, trouble going to sleep or trouble staying to sleep, waking up in the middle of the night. And then fatigue during the day might be because of the trouble getting to sleep, or it might be even if you have a good night's sleep, you might still feel fatigued or just not as strong. And that leads into that next point about muscle weakness. Because of a reduction in hormones, I mean, we know that testosterone helps with building muscles. That's pretty clear. And so with a reduction in those hormones, you can see just weakness of the muscles or difficulty in gaining muscle mass. And then weight gain is also an issue. I generally quote 1 or 2 kilos of weight gain associated with tamoxifen. Sometimes it's more, and sometimes it's not an issue. And the muscle weakness, weight gain, it also ties into the metabolic syndrome. So metabolic syndrome is more of a cholesterol, diabetes type process, which is not good for cardiovascular health. And breast cancer and cardiovascular disease, so heart attack, stroke, are competing morbidities and compete for mortality as well. Erectile dysfunction and impotence are an important thing to be aware of, particularly with the Gazellan injections. There's less data around tamoxifen with erectile dysfunction and impotence, but it's common for tamoxifen to cause a decreased libido, so less interest in sex. It can be a bit confronting to bring up the issue of erectile dysfunction and impotence, but I do think that it's something that is certainly worth discussing with the your cancer management team if it is an issue. Osteoporosis is also something that's worth watching. So osteoporosis is thinning of the bones and can be monitored and managed. So the hot flushes, the sweating, the heat intolerance can be quite significant. It's quite common. It's often of a fairly short duration, but can happen multiple times throughout the day and night. Can cause sleep disturbance and can cause a real distraction. It can be triggered by heat, hot food or drink, spice, alcohol, coffee, tea, chocolate, stress, but sometimes it's just completely random. And sometimes it lasts for a long time. Some people just feel hot all the time. So some strategies with the hot flushes, keeping cool is important, both physically and mentally. So air conditioning, fans, having a handheld fan. If you work at a computer, having a USB plug-in fan can be helpful just to cool things down. Keeping a fan on overnight or even air conditioning. And keeping you cool mentally. So trying to reduce stress, avoid stress, and thinking about how it's going to pass and just trying to not react to it. And there are a range of strategies that can be used for that. Avoiding the triggers if possible, but then again, you might like a drink. If you're willing to have a beer and put up with the hot flush that might ensue, then that might be the trade-off that you're willing to do. Acupuncture can help the hot flushes, and magnesium tablets sometimes help. There's also some medications that can be helpful for hot flushes. So antidepressant called venlafaxine. There's a blood pressure tablet called clonidine. There's a medication called oxybutynin, which they all have their side effects. Pregabalin, the pain medication. So that's something that can be discussed with your oncologist if the hot flushes are significant. Mental health is a common concern, and it's something that has a bit of stigma around it, but it doesn't need to. And I think that there's increasing recognition that we need to speak up about mental health, to ask about it, to talk about it, that irritability, anxiety or depression can be just a bit overwhelming. There's also the cognitive side of it, the memory, processing, the inability to multitask. And that's common after breast cancer diagnosis as well as treatment. And all of that can be exacerbated by the hormone blocking treatment. There's also fear of cancer recurrence, which is under-recognised. And that's a worry that the cancer will return. It can vary, and it's actually normal to have fear of cancer recurrence. I mean, cancer is known to be a life-threatening condition, but it's important to understand your actual risk of recurrence and talk to your oncologist about that. Fear of cancer recurrence often flares before checkups. It flares with reminders. If you hear about somebody else who's been diagnosed, then it can be an issue. And if it's starting to impact on day-to-day activities, thoughts, preventing planning for the future, it's worthwhile to check in and think about some strategies, whether that might be talking to a friend, going and getting some exercise, talking to your GP or oncologist. Checking in with a psychologist is well worthwhile. I can have some really practical strategies, and seeing family and getting onto some good sleep patterns, meditation, and sometimes medication is worthwhile. So you can see bone density on the right. Bone density is not necessarily something you can feel. The bone density, osteoporosis is a very different thing to osteoarthritis. So osteoporosis is thinning of the bones. On the right-hand panel, you can see on the top side, some nice thick bone, and on the bottom part of that, thinning of the bone, where there's much less bone, and that puts you at increased risk of fractures. So broken bones, particularly low trauma fractures in the hip, spine, and wrist. So a bone densitometry scan or a DEXA can be done to check on that at baseline and then along the way to ensure that bone density is not dropping too much, or if it is, to be managed so that it doesn't lead to a fracture. Checking vitamin D, stopping smoking, ensuring calcium-rich diet are also relevant in managing bone density. Exercise is worthwhile, and body weight-based exercise, things like running, jumping, hopping, skipping, putting little micro impacts on your bones helps them to build up. Balance and strength helps to avoid falls, and then bone strengthening drugs can be used for a diagnosis of osteoporosis. Sexual dysfunction. So reduced libido, erectile dysfunction can be issues, and there's the body image issues with a diagnosis of breast cancer. First, it's worthwhile to ensure other causes are diagnosed and treated, like diabetes or cardiovascular disease. Discussions with your partner, just being open about it, thinking about broader horizons, different things for intimacy, such as non-penetrative practices. So not intercourse, but other things. And you're having to think about what else might be worthwhile for intimacy as a broader sense rather than necessarily thinking about sex itself. And medications such as Viagra might not be as effective when taking hormone blocking treatments. Fatigue or insomnia, I talked about a little bit earlier on. And so it's sleep hygiene is something that I talk about a bit. And sleep hygiene involves having regular sleep time, waking up at a regular time, and avoiding screens for at least an hour before bedtime, having a wind down routine, not drinking too much alcohol, because alcohol can help you get to sleep, but it doesn't really lead to a good quality sleep. And that's what you want, is good quality sleep. Regular exercise every day for at least 30 minutes of moderate intensity, managing those hot flushes, avoiding coffee, tea after about midday, and trying not to get onto the medication to try and induce sleep. So that's a short-term fix that can lead to long-term issues. Just to summarise the hormone blocking treatment, it is an important part of treatment of breast cancer for men, and the best outcomes are seen with the full duration of the treatment. Side effects can be troublesome, and they do lead to premature discontinuation, so to stopping the treatment early and before the end of the prescribed course. But the side effects can be managed if the medical team is aware of those side effects. And so speak up, ask questions, try some different strategies. Sometimes it's worthwhile to have what's called a drug holiday. And it's not as fun as it sounds. But what I mean is to stop the tamoxifen or the other hormone blocking treatments, and then have a few weeks off and then restart. And it's not generally unsafe to stop it for a short period of time, because with the hormone blocking treatments, it's about the total duration of therapy rather than being about having a treatment every day. And if you have a break of 4 weeks or so and then restart and you're able to continue on, that's much better than being just up to your neck and stopping it and saying, no, never again, after 2 years when you've been prescribed 5 years worth. Clinical trials are changing to be more inclusive of male participants, and we are seeing a bit of data coming through around men with breast cancer on some of the more recent clinical trials, and certainly at my organisation, Breast Cancer Trials, we are very cognizant of men and with breast cancer, and asking the question, well, is there a specific reason why men should not be included in this trial, rather than taking the default position of not including men unless there's a good reason to do it. And so, you know, we ask ourselves every time, how can we be more inclusive of men on any trial? So with that, I'll move on, hand back to Andrew.
Thank you so much, Nick. I think we can all agree that you know, there was a lot of really practical advice in that presentation, and you know, I think it's something that that anybody that's affected by cancer is constantly seeking ways in which they can improve their situation, no matter what it is, and self-advocacy, and making sure that you're communicating as best as possible with your medical team, and making sure that you're giving them, as you know, the whole picture of how the cancer is affecting your life is really important. Big thanks to Nick. We'll save the questions after our next speaker. I'm privileged to welcome Professor John Boyages to our webinar today. John is a radiation oncologist and a breast cancer specialist with a special interest in lymphedema. I'll hand it over to John for the next part of the discussion. I think you're on
mute, John.
Thank you. Can you hear my screen, and you can hear me now?
Oh, yes, can hear you.
Okay, thank you. Look, thank you for the presentation. I'm a radiation oncologist, a breast cancer specialist, and I work at Icon Cancer Centre and Macquarie University in the ANU, and had a lifelong interest in this disease, and have written a few books on breast cancer that you may have seen, and that's my latest book, Cancer and Vaccinations, Taking Control, and where you can get some of these books. Look, today I'll be talking about lymphedema, which is a difficult condition, largely because people go right through breast cancer treatment and then may end up with a swollen hand or arm, which is a daily reminder that you've been through cancer treatment, and it can be quite distressing. I'm not going to go too much into the lymphatic system, except to say it's sort of the buffer or the joiner between the the arteries and the little capillaries, which feed all our cells, and then the blood goes into the veins, and surrounding this little network here is this lymphatic fluid. And this fluid is important because it has waste products. It's not exactly the sewage system, but it can carry proteins, waste products, and it can carry immune defense cells, and carries that lymphatic fluid back to a lymph node. So the lymph node's a bit like a filter in a sink, so that it filters that fluid, which is dirty, cleans it up, and then puts it back into the venous system. This is a man that I treated recently. Has been through taxane chemotherapy, quite distressing, nail changes, arm changes, actually developed lymphedema of the leg as well, perhaps because of taxane chemotherapy. He's had radiotherapy to the left chest wall, and already wearing a garment, and just another challenge in the middle of everything else that people go through, having cancer surgery and chemo and radiotherapy. Now, we've done a lot of research on lymphedema, and there's no doubt. In fact, this was a study with the BCNA who's hosting tonight. We did a survey of patients with breast cancer, with or without lymphedema. And really in all the dimensions of physical and economic and psychological and functional domains, people with lymphedema had more distress and more issues than just having breast cancer alone. Both are difficult, of course. So what are the risk factors for lymphedema? The biggest risk factor is the extent of surgery to the lymph nodes. And for many men, often they present late and may have disease in the lymph nodes. They may have an axillary clearance. And then again, because not a lot of tissue, they may have radiotherapy to the chest wall and to the lymph nodes surrounding the chest. And all of those things can increase the risk of lymphedema. Being overweight, which is not uncommon in many in our society today, immobility, infection after the surgery, having a seroma, and some of these drugs, such as the taxanes, can all increase fluid retention and the risk of lymphedema. If you feel any of these symptoms, heaviness, aches or pain, tightness, perhaps your ring getting tighter, or swelling that comes and goes, or pitting edema, if you get your thumb and you press it on your lower forearm or around your elbow and it indents, that is a sign of what we call clinical lymphedema. But it's important that we try and pick it up before that stage. It's a bit like mammography in women. We want to get breast cancer when it's small, when even a doctor or a patient can't see it. The same today applies for lymphedema. So what can you do to minimise your risk of lymphedema? How do you look after your arm? These are some questions that people naturally have, and there's often mixed advice out there. I suggest you use your arm normally for home, work, leisure time. Be in tune with your body, look for some of those symptoms, maintain a healthy weight with regular exercise, because the muscles help push the lymphatic fluid along. Use moisturising cream to keep the skin moist, because lymphedema can dry out the skin, allow small cracks to allow germs to go in, and in some situations can produce an infection called cellulitis. Look after your skin and your nails as well. The BCNA has produced fact sheets on lymphedema, and there is some good information on the web. I'm currently writing a new book on lymphedema, which I'm hoping will be out next year. But regular exercises, including resistance training, will help the circulation, the pumping of lymphatic fluid, and also discuss the option of wearing a garment or compression sleeve with your medical specialist, or in particular, an accredited lymphedema therapist. So how do we test for lymphedema? There are many ways, and at the Alert Lymphedema program, we've been looking at some new ways, but the most common way is what's known as a pitting test. Use your thumb and press and see if it indents. And you may see that, for example, when we're on a flight, our legs may swell up and you can see your socks digging into your feet. It's the same sort of thing with lymphedema. In the initial stages, it's reversible, but then later it's irreversible. This is a fancy device called a pyrometer, which uses laser beams or infrared, I think, to measure accurately, or we can use a tape measure. We've done some studies on MRI scanning. You can see all this fluid in the arm and excess fat deposition which occurs, and I'll talk a little bit about that later. And this is some advanced imaging we have at Macquarie, where we inject what's called ICG, indocyanine green dye, which is like a fluorescent dye. Turn the lights off and you can see, and I'll show you some videos in a minute. And this is a quick way called a SOZO device that your therapist or even your doctor's surgery may have, that you can basically take your shoes and socks off, jump on the scale, and it measures subclinical lymphedema before we can even detect it. This is Professor Hiruswamy, who works with me at the alert lymphedema program. He introduced this ICG method, which he brought over from the MD Anderson Hospital in Texas. He's been doing this research for many years and introduced the scanners and the protocols, and we've published on that. Now, there's a lot of myths out there about what happens to your lymphatic drainage after an axillary clearance. You've taken out all the lymph nodes. And these lymphatics are under the skin. We call them lymphatic capillaries and little pre-collectors, very fancy drainage system. And they drain into this superficial collecting system. There's some valves there that are unidirectional. And there's a deep lymphatic system around the muscles and the deep arteries and so on. And we're not quite sure if these systems join each other. We think not. When you inject ICG into a normal person without lymphedema, you can image the superficial lymph collecting system. We can't see the deep collecting system. But as soon as you do that, very quickly the dye goes straight up the arm to the elbow and then up to the armpit. And that's fairly normal. And it's interesting that a patient just lying there, the lymphatic fluid drains so quickly just by muscle movement, breathing, and just by that injection. What happens when lymphedema starts to occur? These lymphatic channels start to break down. It causes back pressure, which goes up into the superficial, into these pre-collectors, and you start getting what's called bridging of the lymphatics between each other, trying to connect to each other, and then eventually goes on the skin, and you can see it along the skin there. And you can push it around just by your hand. You can see that it's you can push it around. In more severe cases, it's called dermal backflow. Everything's broken down. It's not going anywhere. It's mainly going through the skin and under the skin, and you have to use a fair bit of massage to push it along, or better still, a compression garment and massage. And this is what it looks like if you've got a large swollen arm. This is a study we did on over 100 patients who had an axillary clearance. And the interesting thing was that we found that 3/4 of the patients, 75%, despite having an axillary dissection, the lymphatic capillaries rejoined each other and were able to get flow into the armpit. About 40% went around the outside of the arm. There's a vessel system called the cephalic system, goes around the outside of the arm and into the neck nodes here. And these nodes can be damaged with radiotherapy, and in many cases these days I try and de-escalate my radiation therapy and get it off the supraclavicular fossa, because this is a bypass pathway. And so in some patients who've got damage in the armpit, still got this bypass pathway called the Sappi-Mascagni pathway, which was defined in the 1800s. Other patients, the fluid goes this way in a backward flow towards the glands behind the breastbone, and many others, or not many others, 6% go to the opposite axilla or around the back towards the shoulder blade. And this is why very rarely, I've seen it 2 or 3 times in my career, we do see perhaps a patient with a sentinel node that's positive in the other armpit, or a lymph gland that recurs with a cancer cell in the opposite armpit. And it's not that it's spread in the bloodstream, but it's in the lymphatic fluid. So an important question that I've already highlighted is, does early detection of lymphedema help? And we've been using LDEX and what's called bioimpedance for many, many years, initially at the Westmead Breast Cancer Institute, then at Macquarie University. And patients these days can have these results, and you can see we used to use a factor of 10. If it was above 10 compared to the other side, was lymphedema. And this is when the patient reported it. This is when we noticed it. So you can see the difference between when you can do the pitting test and when you detect it by LDEX is about 8 months. When we used a factor of 10, These days, we do a pre-surgical baseline, and if it goes 6.5 above the baseline, which is about here, we then intervene. And this is as early as 22 months earlier, where we can intervene, put on a compression garment, and perhaps even reverse it. So prospective surveillance detects stage 0 or subclinical lymphedema. You can't see anything. It's much better than tape measure, and it's if you pick it up early, it's less likely to progress to stage 3 or very advanced lymphedema. And of course, we can then intervene with education around compression therapy, exercise, and skincare. The really interesting thing about SOZO, and this is what excites me as an oncologist, is that there's, and we're presenting some of this data in a randomized trial we did at Macquarie at the San Antonio Breast Cancer Congress this year, where we're comparing bone mineral content, perhaps as a way of detecting bone thinning after breast cancer treatments. You can look for heart failure, fluid retention, dehydration. You can do it at home. We've done a home monitoring study. And, a lot of patients lose a lot of muscle with chemotherapy and get what's called sarcopenia. And you can measure that and try to have a total holistic approach to getting the patient back on their feet. This is the PREVENT trial, 1,200 patients, 10 centres. We were the largest centre at Macquarie University with 400 of those patients, and we randomised them to tape measure, which is time consuming for the patient and the therapist, or LDEX. And there was less false positives for detecting subclinical lymphedema. We all thought it'd be the other way around, but in fact, there's less false positives, 20% with the LDEX, nearly 30% with the tape measure, and less progression on those patients who are able to be monitored to chronic lymphedema, with an absolute reduction of 11% and a relative reduction of nearly 60%. This is sort of what the company says. I like it because it's easy: test, trigger, treat. They always come up with good marketing things, but to me, it's quite a good, the 3 T's. You test, you test every 3 to 4 months, particularly high-risk patients. If it goes 6.5 above baseline, or perhaps 7 if there's no baseline, put an over-the-counter compression garment, 4 weeks, 12 hours a day, and see if we can get that back to normal. For some patients, you may need to go longer than that. Now, I'm not a lymphedema therapist, but I work with lymphedema therapists. There's a lot that can be done, and it ranges from skincare, as I mentioned before, compression garments, bandaging, exercise, and laser therapy, kinesiology, taping, and this type of compression attached to I'm trying to remember the name of it, but an automated compression device where you attach it, you put your feet up and you watch TV, and you can rent these or then buy them. At the Alert Lymphedema program, we started a surgical program. It's not for everybody, very careful selection. This was our team when I was the founding director. Louise Colmer is one of the leading lymphedema therapists in this country, passionate about it, really convinced me to put more and more resources into the lymphedema. We started this is Dr. Helen Mackey, who's really, I call her the grandmother of lymphedema, really passionate, working initially at Mount Wilga Hospital. We got her involved at our centre as well. This is our first liposuction patient. This poor lady couldn't put on a sleeve, and it's things we take for granted. You just, a woman or a man goes out and buys a jacket, but if you've got a swollen arm, you may have to have it tailor-made, or you can't wear a jacket anymore. And when it becomes stage 3, this fluid, there's a lot of reaction and cytokines, we call them, and I guess I didn't know this until we started the program, that that fluid then stimulates fibrosis and stimulates fat stem cells to produce more and more fat. And our MRI studies show that it's not fluid, it's fat. And therefore, you can't pit it anymore. And garments are a waste of time, and it gets frustrating and costly. And it's nearly a 100% success rate for selected patients, very few complications. We've been looking at lymph node transplants and lymphovascular anastomosis, less successful, highly selected patients, but we've been doing this for trauma patients and a lot of other causes for lymphedema. Now, getting back to the subject matter of facts versus fiction, first of all, I've heard of patients not flying anymore after breast cancer, and that is fiction. You can still go overseas, you can still fly. The data on flying is weak. This was first in 1996 by survey, 5% got lymphedema after flying. This is a good study by Sharon Kilbrae from Sydney Uni, where they got a bunch of dragon boat rowers who were flying from Canada to Australia, and they measured them with the SOZO type device before they flew from Canada, and then when they arrived in Brisbane. And they found no increase in patients who had sentinel node biopsy, but a 4.8% increase in those who had axillary clearance. So my sort of rule of thumb is if you've only had a sentinel node, and many men are just having sentinel node these days, and perhaps you haven't had radiotherapy to the supraclavicular fossa or the axilla, and you're not overweight, you may choose not to wear a compression sleeve, particularly for shorter flights. But if you've had the works like that first man I showed you, maybe wear a prophylactic sleeve to start with. Avoiding injections on the at-risk of lymphedema limb, that is also a fallacy. It's fiction. You can have injections, particularly if many of the patients have very poor venous access. But obviously be careful, use an aseptic technique. If you scratch yourself, put some betadine on yourself or some antibiotic cream. If you get redness, start antibiotics pretty quickly. And if the pathology collector, you're going for your regular blood test, can't get any blood from the unaffected side, after 2 or more failed collections, you can use the affected side for a one-off injection. This is from my new book, Cancer and Vaccinations, Taking Control. I've seen quite a few patients with this type of reaction on the affected side, axillary clearance or sentinel node biopsy, having a COVID vaccination. And so you should always avoid vaccinations on the treated side. Avoiding blood pressure measurements. Again, this is another myth, but if you've got severe lymphedema, it obviously makes sense to do it on the other side. But there are some patients who've got bilateral lymphedema, and very hard to measure blood pressure on the leg. You can do blood pressure measurement on the least affected side or on a side that's had sentinel node biopsy, for example, if you've had bilateral breast cancer. Diuretics, I see a lot of doctors try Lasix or diuretics for patients with lymphedema. As mentioned before, the fluid's in the spaces, it's not in the vasculature. And I think these diuretics can make things worse. So just avoid diuretics. Do not exercise with lymphedema, that's a myth. Exercise improves lymphatic flow. Building up the muscles is really important. With some of the side effects that Nicholas mentioned earlier, building up the muscles, it helps with lymphatic flow. And there's been studies on weightlifters measuring lymphedema. In fact, there was less lymphedema in the studies of weightlifters. Be aware, and I've written a paper on this, and I'm working on another paper, again showing it, that obesity is a risk factor. If you have got a body mass index over 25, overweight, particularly if you're obese with a BMI over 30, and this can happen with treatments, of course, and becoming less active with chemotherapy and so on, and even hormone treatment. This is also an independent risk factor. Extreme temperatures may worsen lymphedema. There's been a couple of studies studies such as hot saunas and that sort of thing. So you've got to be a bit careful, and don't be in total hot baths. Make them a bit cooler, or just warm. And but be sensible and learn to read your body's feedback. Don't operate on a limb with lymphedema. We've done probably now over 150 operations on patients with lymphedema. and there's been studies done on carpal tunnel syndromes and skin cancers. You need to be careful. I'd probably do it under a more antiseptic type conditions, perhaps not just a local GP. You might want to do it with a plastic surgeon or a surgeon as a day only, particularly if it's a large skin cancer. And but you can have an operation on your arm. So if you've got skin lesions and that sort of thing, get them checked by your dermatologist or GP skin specialist, or even your breast surgeon can even help you, and you can have those operations. So in summary, flying worsens lymphedema, probably fiction, but be careful there. Avoid injections, fiction, blood pressure fiction, diuretics fiction, etc., etc. Most of it is fiction, but be sensible. Use the other arm if you can. If they're sticking needles in you on that side, you haven't got any veins left, and you've got these lovely veins on the on the affected side, by all means, with aseptic technique. The Australasian Lymphology Association has a lot of good resources. They've got accredited lymphedema therapists you can get access to. And remember that screening is important. Try to connect with a lymphedema therapist. Skin care, moisturize your arm upwards towards your armpit every day after your shower, and avoid injections where possible. Have some antibiotics handy when traveling. See your GP, get a box of Keflex if you're not allergic to it when you're traveling, just in case you get cellulitis in the chest wall area or the arm. And consider a prophylactic sleeve when flying. You may want to choose the window side if you can put your arm up, and so on. Regular aerobic and graded resistance training exercise. See a certified lymphedema therapist. If it gets tricky, see a centre like the Alert Lymphedema Program for more specialised imaging. See if you're eligible for surgery, and regularly see your therapist, but be alert, but not alarmed. Thank you very much.
Very big thank you for that, John. You know, you've put a heck of a lot of information into that, and I just want to remind people that we are recording this session. This will be available to all the participants today and in the future on our YouTube channel. We might start to field some questions. And John, your last few slides did answer a couple of the questions, which was great. Sorry, I'll just run through that. The first one I want to throw to probably Nick is, we had a question. I suppose that I think in your talk you mentioned that it is quite common for men to be diagnosed at a later stage of their cancer. And question from the audience: if somebody has been diagnosed at that later stage, and the discussion around their prognosis hasn't necessarily been favourable, and the person is thinking about some sort of complementary therapy, what advice would you give in that situation? What would that conversation look like for you, Nick?
Yeah, so I think what we're talking about here is advanced or metastatic breast cancer, which is where the cancer is spread to the bones, liver, lungs, or other parts of the body. And in that situation, the cancer is unfortunately at stage 4 or incurable, and then it is a life-limiting illness, and that's really hard news to hear for an individual and their family and friends. And it's natural to go looking for whatever might help, control the cancer for longer, whatever might help with quality of life, and people will naturally be drawn to what provides that level of hope. with alternative and complementary therapies. So we divide that quite specifically because complementary therapies are those that might be used alongside the medicines that are prescribed. And some of those can provide a good quality of life. They can help with the symptoms of cancer treatments and symptoms of cancer itself. Alternative therapies, by distinction, are therapies that are considered to be used as an alternative option to the prescribed Western medicines. Alongside all of this, I think we need to realise that chemotherapy, hormone blocking treatments, that's only a part of the treatment of advanced breast cancer. And treatment of advanced breast cancer is really about maximising a person's quality of life as well as their quantity of life. So what sort of treatments are we thinking about? Look, my principles here are that many of the complementary treatments don't have enough evidence to say they are definitely helpful. So firstly, we want to think about the theory. Are there any treatments that we're thinking about that might cause harm? Are there anything that might stimulate the estrogen receptor? And that's a no, they shouldn't be used. Is there anything that interacts with the anti-cancer treatments, with the treatments that have been prescribed? And then the Memorial Sloan Kettering Cancer Centre has an excellent herbs database that goes through in a consumer-friendly way all of the different or many different treatments that people might consider using. And look at the potential adverse effects, the interactions, and then beyond that physical side effects, toxicity, there's also the financial toxicity. So sometimes the alternative therapy practitioners can provide unrealistic hope without any evidence to support the claim that they're going to be say making the cancer a whole lot better, or even in some cases curing cancer when we've got no evidence that that's the case. So as you can see, I am quite focusing on the evidence, and for many situations we just don't have that evidence. If something sounds too good to be true, then think twice, think thrice about it. There's been a lot of thought about whether, say, something like aspirin might help prevent breast cancer or might help treat it. Metformin is another one. And unfortunately, the trials have shown very large numbers that those don't help to reduce or prevent breast cancer. And so we come back to the things that perhaps you can do, and that might not be drugs or herbal treatments, but things like looking after your physical well-being, like regular exercise. That's something that is really helpful. And my patients get sick of me going on about exercise, but I really do think that it can provide a lot of help. And seeing an exercise physiologist who's qualified to talk about managing exercise in both the early stage and the advanced breast cancer setting. So exercise is still worthwhile and safe in a medically supervised and professionally supervised way in metastatic breast cancer. As long as there are no bones that are looking like they might be fragile, as long as it's you've got the okay, then I think it's well worthwhile to do that. And minimising alcohol intake is another thing. Having a good diet. So we like to talk about the Mediterranean diet with lots of whole grains, reduced red meat, eating fish, olive oil, so avoiding animal fats, but maintaining those the vegetable fats, and those lifestyle measures that contribute to a really good quality of life. So they're my thoughts around the alternative and complementary, and I think I've expanded a bit beyond what the question asked, but hopefully provided a bit of context.
Yeah, absolutely. John, do you want to add any thoughts as well? Principles of good practice.
The only thing, can you hear me? Okay.
Yes. Yeah.
Yes.
Absolutely. Go forward.
The only thing what was going through my mind as I was hearing that is when my mother-in-law died a couple of years ago of cancer, just the importance of communication with your support people. And I do, the fact that we had a family dinner, she said what she wanted at a funeral, she the will was organised. There's all these sort of stuff that is often taboo to talk about, and often the poor old partner support person, the relationship breaks down as you get sicker, you might be getting cranky with each other, and perhaps children, perhaps it's the time to reconnect with family and friends, and perhaps even think about, some of our patients may do a video or write something, but just remember those other things, because, I sometimes find people spend so much time Googling and wanting to go to Mexico and get ripped off, quite frankly, or even die overseas. And, the tragedy that leaves behind. I'm perhaps not saying it so well, but that's what I'm sort of feeling at the moment. And, I sometimes say to my metastatic patients, look, it's, one of the advantages of cancer is you've got time to plan. When you think of the man got killed in the middle of the road a couple of days ago, Calaro, or someone dies suddenly of a heart attack, someone like Shane Warne, for example, high profile. These days metastatic breast cancer can go on for years and years, and some of these new drugs, the cyclibs that work with hormonal treatments, new drugs come along all the time as well. I'm not trying to give you false hope, but there are, I've seen so many more new drugs in the last 5 years that work for a long, long time. So, in some cases, metastatic bone cancer is like a chronic disease rather than, but I always think, always have plan B. No, you be in control. Know where you want to go if you get sicker. Know who's going to look after you. Make sure all your wishes, and, it might be a prize cricket bat, you want to go to your son-in-law rather than your son or something, you write that down and you will, sorry if it's a bit morbid, but I think being in control is important at this time.
Yeah, definitely. I think sort of picking up on a thread from both of your talks as medical specialists in this area just highlights the importance of having that open communication and dialogue with your medical specialist. We do know the evidence does say that there is a large percentage of people affected by cancer that will explore complementary therapies in one way or another, and it's always really important just to make sure that you're having that open conversation with your medical specialist. You're not going to get judged in any way, shape, or form. It's better to have that open dialogue, so all sort of cards are on the table, as Nick said. If there's anything that is a bit of a red flag from a drug interaction point of view, it's something that you guys really need to be aware of, for sure. All right, I'm going to chat. Another question has come through. I might throw this to both of you, a little bit more specific. is I know both of you have a special interest in supportive care in cancer. In the realm of supportive care in cancer, screening is obviously a really important component. So we've got a question around, in a lot of parts of the country, the distress thermometer and needs checklist is the sort of is the go-to tool in this space. Is this tool valid for men affected by breast cancer? I'll throw that to either John or Nick if you want to take that one.
I'm happy for Nick to start.
So the distress thermometer is something that's been used as a one question: how much distress are you in at the moment? And it's so it's a scale. It's a 0 to 100. How much? And you put a mark on the scale. And so then there are cutoff points at which you'd say, okay, this person is experiencing significant distress. And so clearly that's very broad, and so it doesn't tell us what's causing the distress, whether it's cancer related, whether it's something that's completely unrelated. But it's been validated for cancer, for people with cancer in general. So, and all it does is it helps promote conversations, I think. You can then enter into, if somebody is experiencing distress, then what's causing that distress, and it allows the health team to provide solutions to that. So I think that it's something that's worthwhile as a screening tool, and can help to open up those conversations. And it's not necessarily just with the doctors; it might be with the nurses, chemo units. It could be trigger a direct referral to an assessment team or for further questionnaires. So yes, it's. I am not aware of specific validation in men with breast cancer, but I don't see why it wouldn't be valid.
Yeah, definitely. I would agree wholeheartedly. The next few are for probably more for John from a radiation oncology perspective. Are you able to explain, I suppose, give a general snapshot of the specific side effects of radiotherapy treatment for men experiencing breast cancer? But there's a specific question around the connection between breast radiation and chest radiation and heart issues as well.
Yeah, they're very good, very good question. Side effects are acute or late. The acute side effects are ones that occur during treatment or soon thereafter, but probably week 1, nothing much, week 2, nothing much. Week 3, skin starts getting a bit red, and if we're treating above the collarbone, you may have a little bit of trouble swallowing dry food. So I recommend soft foods, and not sort of hard bits of steak or toast or hot chili or hot soups, for example. The late side effects, one that I sort of mention in my book, is a lot of people feel that men don't have breasts and therefore mastectomy is not as bad as for a woman. And the reality is having a scar right across your chest and then giving radiation, for example, for example, men with hair on their chest means you have hair on one side of your chest because you may lose all your hair, can be quite distressing. And there have been trials of breast conservation now that I've written about in my book as well, that if breast cancer is picked up early enough, there's no reason why a man can't have a lumpectomy and then radiotherapy and to preserve the nipple. Not done a lot. I've never seen it done in Australia because usually it's sort of too late by the time I've seen the patient. They've had the operation and they've been referred. The heart, we're getting a lot better at these days. There's a technique called the deep inspiration breath hold. You take a deep breath. Quite amazing that just by taking a deep breath, the heart narrows and all our angles improve, and we can get very, very low doses to the heart these days, very safe doses. Some of the chemotherapy drugs we use can affect the heart, so it's important to keep in touch with your GP and your oncologist about that as well. There's a whole bunch of rare side effects, but most people don't get them. The worst part about radiotherapy, often the parking, coming every day, but most of my patients can continue to work. But if they need time off, if they've had tough time with chemo and taxanes, and then of course use the radiotherapy as a time to recover, and just come for about half an hour a day, have your treatment, get home, and probably not just rest in bed, but start exercising, building up your muscles.
Definitely. It's a nice little segue into the next question. Open it up to both Nick and John. I think John, you just touched on employment, and sort of we know that employment in cancer is absolutely a very pertinent issue for anyone who's living with or beyond any type of cancer. What sort of discussions or advice do you have with your patients around with continuing work, stopping work, the whole myriad of challenges that a cancer diagnosis and treatment can present?
Yeah, look, I think the first thing is that sometimes you may be told, "Oh no, you can continue to work," and then you get complications from your chemotherapy or radiation, and you then feel guilty that you can't work, perhaps. So I think if you need time off work, have time off work. You don't owe it to anybody not to work. If you've got sick leave, that's good. If you've got disability insurance, that's good. But obviously some of these have got a 3-month window. Many patients find working is healthy for them. They go home and they look at the 4 walls and they worry more, whereas if it's really just some radiation and some tamoxifen tablets, once you've recovered from the surgery, maybe 4 weeks, maybe 6 weeks, getting the shoulder moving, you can get back to work, or a lot of working from home these days. So it's tricky. You need to have that conversation. It could be financial concerns. It could be to do with in a high-powered job and deadlines and feeling guilty leaving that job. But sometimes you just got to say, look, let's stop. Let's spend time at home with the family, watch some Netflix and some movies, and just chill out, and use this time of breast cancer to reprioritize, have a think of the next 5-year plan going forward. See this as a hiccup, but not remembering that I think it's about 30% of patients have post-traumatic growth rather than post-traumatic stress. And so there is opportunity to grow after cancer as well, and perhaps improve your health and your exercise and your heart health and a whole lot of other things, perhaps even change jobs.
Excellent. Nick, what about you? I definitely echo what John was saying just then. I mean, you see that some people have, and the ones who really seem to thrive can either take that breast cancer diagnosis and they use it as a catalyst to reprioritize, to think what's really important, what do I want to keep in my life, and what's perhaps not so important that we can leave behind, whether that be work or other things that are not contributing to quality of life. It is really common to see reduced employment after a diagnosis of breast cancer, and it can take up to 2 years for the side effects of chemo, for example, to really improve to the point where they're not going to improve any further, and what I'm then implying is that sometimes those side effects don't ever resolve completely. so that's the unfortunate reality. It's just that balance between maximising survival in the early stage setting and maximising quality of life. And sometimes there is a dual opposing purposes there that just needs to be weighed up.
Absolutely, well put. I think we are, I think we have gotten through all of the questions so far.
There was a question that was posed directly to me, which is my thought about how long a patient should be on tamoxifen. So, Andrew, you might not have seen that in the chat, but I'm going to, I'll address that if you don't mind.
Yeah, go for it, go for it.
Yeah, so I did allude to this during my talk, that there's variable duration of hormone blocking or endocrine therapy. And so the early trials indicated that 1 year of tamoxifen was better than none at all. And then there were trials showing 2 years was better than 1 year. And then there was trials showing that 5 years was better than 2 years. And then there were trials showing that 10 years is better than 5 years. But I think that there's a bit of nuance there. So not everybody needs the full 10 years. And the subgroup analyses of the trials that were looking at the 5 versus 10 years have indicated that the bigger benefit is seen in those with a lymph node positive cancer or a tumour of more than 20 millimetres in size, and so it's understanding the baseline level of risk. And so, you know, I start to get a little bit technical here in how I describe risk, because when you've got a very good prognosis, so, you know, say you've got a 99% chance of being cured of breast cancer, and I halve your risk of the cancer coming back, that's taking you from 99% to 99.5%, which is a pretty tiny increase, even though you say, oh, look, it's a 50% improvement. So if I say that I'm doubling your chance of winning the lottery, do you rush out and buy a ticket? So that takes you from 1 in 500 million to 1 in 250 million. And so it might be a 50% improvement, but the actual chance of going and winning the lottery is still exceedingly tiny. Now, I'll take another scenario, which is where you have, say, a 50% chance of a cancer recurrence with a high-risk breast cancer. And if we're reducing that by 50%, it means that we're taking your chance of cancer recurrence from 50% down to 25%. And so that's a substantial benefit, still a 50% gain, but it's an absolute benefit of a much larger amount and much more likely to be clinically significant. And so that's where there are nuances with the risk of recurrence and how much somebody stands to gain versus the potential side effects of taking one of these tablets for an extra 5 years, because those side effects do persist during that time, and they don't necessarily just settle down within the first months to years.
Brilliant, thanks, Nick. If any other queries, any other questions for the panel, throw them into the chat now. If we've got any other.
So while people are thinking, if there are any other questions, what I do want to briefly mention the clinical trials aspect of it, because I also alluded to this, that that we just don't have as much evidence with cancer treatment in men. And That's something that is shared by a range of other so-called rare cancers. Or that being said, the fact that 212 men are expected to be diagnosed this year, whilst it makes breast cancer relatively rare, it's more common than some of the other rare cancers out there. So we look to population studies, and there are population studies out there focusing on men. It doesn't give us the same level of confidence, but from the other aspect that we look at is biology, and there are studies that are underway at the moment looking further into the biology of male breast cancer. What's going on in those cancer cells, and how different is it to female breast cancer? How much can we extrapolate versus how much do we need to change? And then just being more inclusive in clinical trials, and at breast cancer trials, which conducts those trials that tries to answer the questions that maybe the big pharma companies aren't quite so interested in answering. They're the questions that might not necessarily have as much of a profit motive, but are still really important. We're looking at getting more men into our trials, more rural and regional patients into our trials, diverse backgrounds, Indigenous, people of culturally and linguistically diverse backgrounds, so that it's more representative of the patients that myself and John treat in the clinic. And then I think it's always going to be very challenging to run a trial that's purely for men, but getting those men into the trials and offering them that opportunity is becoming increasingly commonplace.
I might just say one last thing as well. Nick just reminded me that the other dimension we need to look at is genetics as well. There's often have a look at your family history. A lot of men, we get genetic testing. There may be a link with the BRCA2 gene mutation. There's often a link with prostate cancer, so get your PSA done on a routine basis, probably every year. And thank you to BCNA for hosting this.
Brilliant. Thank you. Before we close out the session, I just wanted to draw everyone's attention to the My Journey app. This is the go-to app, no matter what type of breast cancer you've been affected by. It provides you with the latest information to suit your needs and suit your situation. There's a symptom tracker. I think we talked a little bit about self-management today. There's a really fantastic symptom tracker that you can use to help you manage some of those really tricky side effects that both Nick and John have spoken about today. Some other specific resources also, just to mention here, our podcast and our series of webcasts as well. Here's some more. We have the Beacon, which is a quarterly newsletter for all of our members at BCNA. We have an upcoming webcast, Food and Movement when living with metastatic breast cancer on the 23rd of November. So please jump on the website and register for that if you are interested. A couple of podcast episodes we've touched on work and breast cancer, and we've also a podcast specifically around men and breast cancer for raising that awareness. I think we've got some gents on today, which is fantastic. I really want to thank everyone for joining in today. I think it's been a fantastic presentation from both Nick and John. We've jam-packed a lot of information in today. If anybody is on the session today and you do need help or support, please reach out to our support line, contact at bcna.org.au. And there's also always the Cancer Council, the 131120 to speak to a cancer nurse as well. There's some other websites as well that might be of use to people. A really big thank you to both of our speakers today, and to everyone who's participated. It's been a really great session, and we really want to keep the conversation going and raising the awareness of breast cancer affecting the 212 men that will be diagnosed in 2022. So with that, we'll bring the session to a close. Thanks, everyone.
Thank you.
Thanks, Andrew. Thanks, Nicholas. Thanks, John.
Pleasure.
Thank you. Pleasure.